Can you guys see my screen?
Yes.
Fantastic. So I pull these cases on offline. I like Google and see which ones look legit and work through it. And the reason why I do cases is, they teach us a lot of facts on, in medical school and residency. And for me, I learn best with like repetitive case-based scenario, case-based practice. And for example, the last week, I think we've done probably over 10 hours of stroke cases. So now when I go into a stroke case, I'm not learning the emergency stroke when I'm having the emergency with the patient. I've learned it. I know it better. So then when I go into the emergency, it's not as stressful as if I'm learning it for the first time. And I think that this adds to the medical training because there's times where, for me, I feel that I want to get more of this kind of learning and also learning it together with other people from other backgrounds and other hospitals. So that's why I designed it like this, instead of us doing like, okay, like the things that you can read on your own, it's kind of not really how I structured these set of years. It's more so let's get together. We've all read, let's all just come and work through cases because these are stuff we're going to see daily, day in, day out, no matter what field we go into. So with that, let's work through this case. Who would like to take it away?
I'll be happy to kind of start it.
Cool.
Okay, so Michael is a 61-year-old senior partner in a law firm. So while eating breakfast, Michael experienced sudden onset slurring of speech, had facial droop on his left hand side with weakness in left side, upper and lower limbs. So I'm kind of already thinking localization in the right hemisphere.
Mm-hmm.
That's of course if he is, well, I guess we'll have to see if he's left-handed or right-handed, but nonetheless. So Mary spotted the sudden onset of symptoms and immediately called for an ambulance, which arrived within 15 minutes.
Awesome. So let's stop there. So a big thing as you're hearing symptoms is like, okay, where does it localize, like you said? So we have sudden onset slurring of speech. Speech, more than likely, he's probably right-handed. A lot of the population is right-handed. So that means that the language is on the left side, left frontal parietal temporal region. So, okay, we say that this is going to localize to the left side. He has facial droop on his left. What? On his left-hand side. That's weird. He has left facial droop is how I would say that. So if he has left facial droop, that would localize to the right side.
Yeah, that's where I was a little bit confused. I was like, wait, so we have aphasia, which is predominantly on the left frontal, but then we've got symptoms on the left side. So,
okay. Well, left side, upper and lower limbs. We know that is definitely right side. So maybe he could be left-handed. That would explain the speech being on the right.
Right.
Facial droop on the, left facial droop on the right and left upper and lower extremity. Right?
Yeah.
Cool. And so we talked about Circle Willis. So and I like to tell you guys what's going to be high yield on like your step 2, step 3 exams, since I'm not too far removed. So they love like big Circle Willis distribution. So you guys remember the homunculus? Let's Google that. Don't make fun of me because I don't know how to spell. So let's see, That's why I love what's this thing, because they'll correct it for me. They know what I'm trying to say. See, it's like they're in my brain. So you guys know the homunculus, the face and the arm is more MCA distribution, and then the leg is ACA distribution.
ACA, yeah.
Okay, so if we go back here, and so he has left upper extremity weakness. So where would that be, ACA or MCA?
MCA.
Good. And then what about lower limb, ACA or MCA?
Both.
It's purely lower limb. If we go back,
lower would be ACA then, yeah.
Yeah, because where did this go? So if we go back and look at that image, you see that the leg. I love my annotation. Let me find my annotation. So you see here that the leg is the ACA. So purely leg, ACA, and then like you guys said, face, hand is MCA. So this means that this guy already has multiple territories involved for his stroke.
So are you thinking like it's either got to be something really proximal and or just it's a large stroke?
Yeah, it could be proximal, or he could be showering a lot of clots. So that's another good point. So let's say he is right-handed and then he has slurring of the speech. So that's the left hemisphere. And then we've localized these other two to the right. So maybe he's just showering clots at different parts of the brain. And that's why we're seeing bilateral
infarcts or symptoms, right?
Yeah. And if anyone has questions, feel free to ask. Well, and a lot of this stuff is very high yield. So wife spotted, he arrived within 15 minutes. That's good. And this showed up on step 2. They had it, or maybe it was neurology self. The question was, what is the time frame for which you can give TPA after symptom onset? And it used to be 3 hours, but now can extend it to 4.5 hours. So no, that is a high yield for, I think, neurology self. They love those questions. Okay. So now we have past medical history. So which of the, here's some good question. Which of the following puts them at high risk for stroke?
Hypertension.
Right. And that's a really high common risk factor for stroke. Asthma, you don't really care about it from a stroke standpoint. Pre-diabetes, they could put him at, you have to watch his sugars because diabetes is a risk factor for
small vessel disease, particularly. So, but he's at the pre-diabetic phase. So certainly hypertension is going to be something that's going to we're going to attend to.
Exactly. Because I don't know what this is. Oh, inhaler. Okay, that's asthma medication. This is also asthma medication, and this thiazide is for
hypertension. Yeah.
Keep that in mind. Works at a law firm, so probably a stressful job. So big important things if we find this person in the emergency room, from a social history standpoint, what do I care about?
If he's a smoker. Great.
And he is a smoker. He smoked for a long time. Ex-smoker, smoked for 30 years. So that's another high risk factor for stroke. That's one of the big things I want to know. Does he smoke? And what's his baseline function? Because that plays into, can we give him TPA or mechanical thrombectomy? So it looks like he's still working. Probably independent. As he walks, so he's probably pretty functional at baseline, and he golfs, and he also drinks at times. Okay, great. So now that's the information. When we get to vitals, the biggest thing we want to know is his blood pressure, because if he is in the emergency room within 15 minutes of onset and we want to give him TPA, this is also high yield. This will show up on all your boards. Neuro or shelf, step 2, step 3, they love the TPA criteria for blood pressure. So the question would be, you have this patient, which of the following is a contraindication to TPA? And if the person, my sister's here. Let me see. Okay, hey sis. I'll wait for her to get situated. So the question that they love asking, which of the following is the contraindication to TPA? And the blood pressure is 185 over
110.
Okay.
Correct.
Or is it 190?
110. 185 over 110 was the strict criteria for contraindication of TPA if it's above 185 over 110.
Is it 185 or is it 190?
185.
Okay, cool. Awesome. So they love that question because I've seen the patient will have a blood pressure of 190 over 110. And they say, can you give this patient TPA? So if you don't remember, oh, the cutoff is 185, then you would be like, yeah, we can give them TPA, but you can't because the blood pressure should. So know that from a stroke standpoint, the cutoff for TPA is 185 over 110. And the reason why that is a contraindication is the higher your blood pressure, if you give someone a blood thinner and you have a lot of intracranial pressure, it can increase the risk of hemorrhagic transformation, meaning bleeding into the stroke. And that's not what you want because that has a bunch of other symptoms. So.
And I just went ahead and just fact checked just so that you were aware. I did just look at MD Calc and it is in fact 185 over 110. Awesome.
Thank you. Thank you so much. Because, sometimes I forget. Very good. So that's the big thing we want to know. Here they're doing the fast. Pretty much we would be doing a stroke scale, and he has left facial droop, left motor weakness, worse in the upper extremity compared to the lower extremity. So again, this still localizes to the left side. Left facial droop localizes to the, this localizes to the right. This localizes to the right. This localizes to the left if he's right-handed.
I have a quick question.
Yeah, go ahead.
And this may have been discussed and I probably missed it, or maybe it was in the paragraph, but so we assumed that so I guess the case is what told us, but how would you know if it was like a hemorrhagic stroke versus like a clot?
Great question. We don't know yet. What's up, sis? Okay. You want to introduce yourself?
Yeah, sorry I'm late. My name's Ade. I'm Essie's younger sister. I'm an emergency medicine physician, and really excited to learn more from her and hopefully help teach based on my experience with strokes. I'm just listening.
I'm just loving this female magic right here. Do you see all this? I'm just loving it. This just makes my day. Yeah, Addie, chime in whenever. Ask questions. It's free.
Yeah, I had to give EA to Mama, but I was listening in when you guys were talking about the cutoff for stroke. Mm-hmm. And one thing to keep in mind, and that we do all the time in the emergency department, is you could just always give a quick dose of labetalol to quickly lower the blood pressure before giving TPA. It's just it's contraindicated when you push the medication. And then there's also a different, I have to look it up. There's a different limit for when the medication's actually infusing, a blood pressure limit for when the medication's actually infusing that you want to keep it below.
So say that again. So it has to be 185 before you push, below 185
yes.
When you push TPA.
Exactly. And there's another limit at when it's actually infusing. I'm gonna look it up right now and then get back to you. But
thanks.
Now,
because the patient has that blood pressure, doesn't if that's the only contraindication, you just quickly fix that
right
with some IV. Labetalol is a blood pressure medication. It can push IV. It's very quick, acts very quickly.
How much do you push?
5, 10.
5, 10.
How much it takes, and then you can
get
the TPA.
Thank you for bringing that. Actually, that brings me to another point as far as so now there's a second criteria of okay, maintaining the patient blood pressure. Isn't there an upper and a lower limit though? Because you want to also be concerned about if you drop it too low, then we have hypoperfusion going to the brain. So is there a range keep them between 160 and 185 systolic or something like that if it's an ischemic stroke? I don't know if there's a protocol for that. Do you know what I mean?
Yeah, I think you don't want to drop them too low. I think if a patient comes in, Addie, you would know this better than I do, and they have hypertensive emergency, I think you can only drop them a certain percentage. I want to say, was it so many numbers every, I need to look this up.
I know exactly what you're talking about.
What you're getting at, Laura, is the concept of permissive hypertension, because when you have an ischemic stroke, there's blockage that's preventing blood flow to the brain. And so the body will compensate by elevating the blood pressure to try to force blood to perfuse the brain where the flow is blocked. And so you're right there. You do allow for the patient to be relatively hypertensive
Right.
To make sure they can get some of that benefit of perfusion, but then there's a range that you want to stay in between, because like Dr. Goodall said, you could.
I was thinking that I like there's that upper and lower limit, but then in the complete opposite being true for hemorrhagic strokes, you definitely want to aggressively like bring down their blood pressure, correct?
That's right. Yes. So knowing the different types is important, because how you manage it is different. I'm gonna find the blood pressure.
I would think though at the hospital that it's like part of the entire like care set, like the acute stroke like care set, and it has like all those, for like the care set to like all those like parameters where it kind of is like a cute cheat sheet to like be able to know upper and lower limits.
Yeah, exactly. Yeah, I had to look it up every time.
Since we're talking about, for me, repetition helps. And although I know we've talked about this multiple times, when we see it multiple times, it'll like stick. So in an emergency situation in a patient with a stroke, the biggest thing, the reason why they call a stroke code is this person candidate for TPA? That's the first question. Yes, no. And are they a candidate for mechanical thrombectomy? So thing we could do at the bedside is figure out, are they a candidate for TPA? And so here the contraindications: absolute if they have a brain bleed. So that goes to your question, Joy, about, well, does this person have a brain bleed or do they have a ischemic stroke? We won't know unless we do a CT scan. So as soon as this patient comes into the hospital, we're going to bedside doing like a very quick Nih Stroke Scale, or more than likely like, hey, stroke alert, just send them to CT. I'll meet them in CT because I'm going to need a CT head anyways. And the reason why you're going to CT is to rule out brain bleed. That's the only reason. And that, because they love asking that question on rounds, why are we going to CT head? To rule out brain bleed. Because if it's a brain bleed, TPA is a no-go. So absolute contraindications to TPA is hemorrhage, subarachnoid, presentation is concerned for subarachnoid hemorrhage, recent neurosurgery or head trauma within 3 months, and then like Laura talked about, this uncontrolled hypertension, and like Dr. Osamah mentioned, we can always give labetalol 5 or 10 milligrams IV, and that'll get it down. History of intracranial hemorrhage, known AV malformations, neoplasms, or aneurysm, and the reason why is this will increase the person's likelihood to bleed. Active internal bleeding, biggest ones are GI bleeds and GU bleeds, because those they're not compressible, and you cause someone to bleed internally, Dr. Osamah is going to be like, what happened? This person had a stroke and now my patient has a GI bleed, and they're going to be having to do a whole set of other things. And I read this recently. If you think the person has endocarditis and you think that the stroke is due to an endocarditis patients, they call them septic emboli, they love to bleed. It's just known, stroke due to infective endocarditis, they're going to bleed. So if you think that, they're having symptoms of endocarditis, they're having like you guys help me out, the little
flubbing.
Yeah. Or like,
are you talking about like the Janeway lesions?
Yes,
and
yeah.
There
we go. And
don't bring me back. You're bringing me back. You're like
they
the
have
Janeway lesions. No, yeah.
They have like,
Janeway and the Osler
issues. They have
yes, Osler nodes, all that.
Yeah.
And that's how you'll too. They love infective endocarditis.
Oh yeah.
So if you think that they have, concerns with infective endocarditis, don't give them TPA because they're going to bleed, and that's going to be really bad.
Yeah, I mean, you can imagine, like, you can literally see like the microhemorrhages in their fingers and in their hands. Like those same spots are in the brain, and so like they're bleeding in their hands a little bit. If you give them TPA and they have spots in their brain, they'll bleed. So like Dr. Hidar was saying, you definitely do not want to give TPA. If someone has any suspicion of endocarditis, don't do it. And
sometimes for me, when I get called on a patient and they have like a hematological cancer, I want to know, okay, what are their platelets? Because if it's less than 100,000, they cannot get TPA because they're going to bleed. So bleeding, diastasis, Am I saying that word right?
Yeah, it sounds right.
Okay. She said it sounds right. Oh, God. Okay.
It's however you say it. That's what it is.
You're so funny. So platelets less than 100,000 if they've received heparin. Laura, I think you had asked a question about reversing a couple of days ago. Addie, have you ever seen it in your practice reversing? I haven't, but I just wanted to touch base and make sure it had like reversing anticoagulation to give TPA, because my thought was even if you reverse it, it's going to take a while for the medication to become subtherapeutic and still in their system, and you're just going to bleed and it's just going to be horrible.
I've never seen that.
Yeah.
I have to look into it. I know like, let's say someone's on warfarin and you're monitoring their INR. Like it's not on warfarin, it's the INR that's a contraindication. So perhaps you can reverse, give vitamin K, fix the INR. But then I don't imagine that happening within the 4-hour time frame.
What I can do is I'll write down these questions and ask my stroke docs.
Yeah, that's a good question. No, I've never seen it.
Yeah, get back to you, because if someone just took warfarin, but their INR is 1.5, do you give TPA? So I'm gonna write down these questions.
Yeah.
To ask the doc.
Is the INR?
Well, INR 1.5 would not be contraindicated according to MD Calc.
Right.
Always.
However,
so you have the test answer and then you have the real life answer.
Right.
With it depends, right? Like if this is like a young 40-year-old and they just happen to be on warfarin and they were living their best life prior to this, then obviously you want to be a little more aggressive with their treatment if there's a way to reverse their stroke symptoms, versus like maybe this is this person's third stroke and like they already have that, they already have deficits, and you're just the goals, their outcomes are a little bit different. So it always depends, and whether or not the person in front of you can have like an actual like risk benefit discussion. But for the test, based on INR, don't be confused and say, oh, they're on warfarin, I can't give it. No, the INR is within goal. Give it.
Another question I had, I know that this is debatable. How long, I think I was talking to one of the other attendings who joined in a couple of days ago about if someone, and see, this is the beauty of these study groups, because this is real world, like when you see a patient, they give us the cookie cutter board, question, right? But when you see the patient in the hospital, they're never going to be cookie cutter. It's going to be these little nuances. Oh, well, they're on this, but they're on this. So, but they have this. And doing these study groups kind of helps tease out all the different scenarios so that, you're ready. So if the patient has been took their anticoagulant a week ago, do you still use TPA? I know some people wait like, oh, if it's been 3 days, I give it. It's been a week, I give it. Like, Addie, do you know, like, is there a specific day cutoff to where, okay, I'm not going to give it? Like, if they got it today, yeah, that makes sense. But if their last dose was 2 days ago, can you give TPA? That's a question I was going to ask.
It depends on, so every drug has like the half-life. So this would be like, I reach out to my pharmacist and say, hey, when is this drug supposed to be out of their system?
Okay.
I imagine like, and you can kind of get a clue based on how often a medicine is dosed, right? If you're taking a medicine 3 times a day, that means it's going to be out of your system like every 8 hours. If you're taking a medicine once a day and they took it 2 days ago, you can imagine that like it's probably not in their system anymore. So you can kind of like guess based on how frequently they're taking. I mean, that's not the case for all medicines, but in a medicine that's not titrated up, that can be a clue. And then you could just quickly up to date, what's the half-life, but that's not a decision I would make without like talking to like my pharmacist.
Right, that makes sense.
And theoretically, that the compliance or the frequency of the medication, theoretically, that should line up with the INR, assumingly. Mm-hmm. Yeah.
But then there are some, so I think what Dr. Igdauer is getting at is, so you measure INR for warfarin, but then there are some other anticoagulants where you can't really, there's no measurement There's no like
Eloquence
lab.
or like
Exactly.
Pixaban or Lovenox.
Mm-hmm. Okay. Yeah. So absolutely.
That's where it gets kind of tricky, but I my gut says if you haven't taken it within the past 24 hours, you're probably good, but I would ask for help before pushing TPA.
All right, thanks for this. The time limit or BP limit when giving TPA 185 to 110, BP limit doing TPA 185, 105. Thanks.
Yeah, it's like a subtle difference, which I imagine is just based on like how they designed the protocol for the research. But
here's another high yield. Before you push TPA, check the patient's glucose, because glucose, hypoglycemia can look like a stroke. So that's another question that comes up on not so much self, but maybe step 2, step 3 is check the glucose, get a CBC.
That's a contraindication for TPA if the glucose is less than 50.
Yeah, get a CT head. And then here's some relative ones. If their symptoms are improving, major head surgery, GI or urinary tract hemorrhage within 21 days, seizure at stroke onset. And I was trying to remember why this was a relative contraindication. Someone explained it to me, forgot. Seizure at stroke.
I mean, the idea is that like stroke shouldn't cause you to have a seizure. You get seizures from like a lesion. So that clues you into it's probably a brain bleed, or maybe they have mass from endocarditis or from cancer. So
right,
not complete contraindication, but relative, because
there should be something else that there's something else that's possibly going on instead of an ischemic stroke, essentially. Exactly. Yeah.
Okay.
You know,
so ischemic stroke should not cause seizures.
Mm-hmm. Right. Hemorrhagic or tumor or like an infection or like drugs, but it would clue you in. I think that's what Dr. Adi was kind of sort of cluing into. Like you need to clue into other differential diagnoses if we're having
right. You know the presentations of all these different strokes and the lesions. Like I don't remember a seizure being any like
a major presentation for stroke. Yeah, that's a good point. And then another one is recent arterial puncture at non-compressible site. So let's say they went and they did like a stent for their heart 6 months ago. The femoral artery is compressible, so that's not a contraindication. What they're getting at here is if they've recently undergone like a dialysis, catheter placement, or port. Those are not compressible sites. Yeah. So
they have their appendix sticking out or something.
Yeah.
So go
ahead.
Here's a tricky part though, because there's always like laws to the land. What does recent mean? Does that mean the last 24 hours? Does that mean there's so much discretion there that I guess either that can be to your benefit as a physician, or it can be like it looks like that's a little gray. And I know, that might be a good thing for you guys practicing as a physician, like, well, that gives me more room to like do my own independent thinking on that.
Right.
And discretionary practice.
Exactly. Right. You're exactly right. And then having a discussion with the patient. Hey, here are the risk benefits. This is relative contraindication. It does put you at high risk for bleed, but it's not absolute. Here are the risks. What do you want to do? So yeah, you weigh the risk benefits. Recent lumbar puncture. So if it's been like 2 weeks, it's far enough to where, the site has been plugged off. It's going to be, less chance to bleed. If they've had an LP yesterday, you probably don't want to give TPA because they're going to just have a hematoma. Recent myocardial infarction, pericarditis. So I remember bringing this up to another attending, and she talked about why this could be a contraindication is because you could induce like cardiac bleeding or hematoma in that side if they've just had a MI due to pericarditis. That's how I understand it. Pregnancy, everything's contraindicated in pregnancy.
And the reason why I think they're contraindicated in pregnancy is because no one ever studies.
Exactly. Right. Because I wouldn't want to be the principal investigator studying a drug on a pregnant mother, and then the baby comes and it's not, So let's see. Additional warnings if they're greater than 80, prior stroke or diabetes, and prior stroke, you just want to know how, because we have pushed CPA in patients who've had prior strokes. You just want to know how far out is the stroke so that it doesn't increase the risk for hemorrhagic transformation. Any active anticoagulant use, even if INR is less than 1.7, kind of what we talked about, use discretion, talk to your pharmacy. If the NIH is greater than 25, because when you, well, depending on like your hospital's algorithm, there is a cutoff to give TPA. If the stroke is too big, like if it takes up more than 1/3 of the cerebral hemisphere, that's a huge stroke. And the bigger the stroke, the more likely it is for it to bleed. And so that's why they use this, you know, warning, hey, if the stroke is huge, use discretion. And that's what they're getting at here, because it may not be worth putting the patient at risk for bleed if their stroke is so big. And that's what they're talking about here. CT shows multilobular infarct, hypodense region greater than 1/3 of the cerebral hemisphere. Cool.
So may I just pose a question?
Yeah.
And I this is going to be something I would like to sort of definitely hear from Dr. Adi, because you're in the ER. So of course, everyone gets their non-contrast CT for sure. Not even a question. It's part of the stroke protocol, period. EKGs, I know they're done like everyone gets EKGs or roll into the ER. Is an EKG part of the stroke protocol, or is it like, hey, we can slip it in because we're multitasking while we're working up this patient? Would you delay care to do an EKG for a patient that we're trying to give TPA and do the CT, et cetera, et cetera? Like, is it actually in the stroke protocol, or is it like, hey, we find that we end up getting it in? Do you know what I mean?
It's a great question. On the surface, it could seem like it's extra, but then if you go back to the contraindications, a STEMI is a contraindication for TPA. You're not going to know about that if you don't do your EKG. Also, the EKG can give you clues as to why they're having a stroke in the first place. A lot of times, first-time AFib, which can throw clots throughout the vasculature, can be a reason for their stroke. And so
exactly,
you can kind of, you're still going to manage their stroke and give TPA, but you can get an idea of whether or not this is the reason for it. And then on top of that, if someone is an AFib and they're unstable, that's something you're going to want to manage, because now that's more of an emergency above the stroke. So I would argue that you should do an EKG for every single person who comes to your ED, who you think you might give TPA to. Now, it can happen after the CT brain, because if this is someone who has a brain bleed and you're not going to give TPA to, you don't want to waste time doing an EKG when they really just needed the CT brain. In my practice, a lot of times that's something that can happen. The EKG tends to happen right away, mainly because the patient's in the bed, you have to get vitals, the neurologist has to evaluate them, you have to evaluate them, ask questions from the family, the CT scanner has to be ready. So usually by the time they're ready for CT scan, the EKG has gotten done. But if you haven't looked at it at the EKG, you should look at it before you do TPA. Because if someone has a STEMI, it's a whole new thing. They're going to the cath lab. They're not going to the neuro-ICU service anymore.
Thank you.
Yeah.
Phenomenal discussions. Okay, so we got through social history, got through vitals, talked about the exam. So here, I don't use this pre-stroke screen. Basically, we just do Nih Stroke Scale. And here, physical exam confusion. We talked about all this, decreased tone, mild left-sided neglect. So if they have mild left, here it is, Nih Stroke Scale is 19. So mild left-sided neglect, that's the non-dominant
parietal lobe. Mm-hmm.
So
typically the right side, typically.
So this guy this is right-sided symptoms, right-sided. So right now we're thinking this dude has a right-sided ACA, MCA stroke.
Mm-hmm.
And then here's Nih Stroke Scale. So here are the different components, level of consciousness. The two questions are month, age, do they follow commands? And I think there's a standard 2 commands that you ask. I can't remember. I think I can't remember the commands, but it's the stroke scale. You can print it off, and that's if you're a resident or attending says, hey, go do a stroke scale, this is what they're talking about. What's their best gaze? You're looking for pretty much testing the horizontal gaze only. We don't care about vertical, it's the horizontal gaze. Visual field testing, do they have like a homonymous hemanopsia? You just do, cover. Well, I see some doctors do, because you're really looking for binocular vision loss. And it's like, how many fingers do you see? How many fingers do you see? Face palsy. And then here you're testing motor and all the extremities. And the arms, it's 10 seconds. And you ask them, raise your arm up, hold it for 10 seconds. And if they drift, you score them. If they can't lift it, you score them. Legs, it's 5 seconds.
For the commands, I want to say, I'm just kind of thinking in the back of my head, is one of them like, give me a fist, open your hands? I think that's one.
Yeah, let's look it up.
Or, there it is. Actually, open your eyes. Oh, okay.
Open your eyes.
Release. Love that. Okay.
What was it?
Open and close your eyes, and then grip and release the hand that's not affected. Awesome.
Thank you. And then limiting ataxia is really, finger to nose, heel to shin. And note on the stroke scale, here's something that I see all the time. If a patient has left-sided weakness and they can't do finger to nose, you only score ataxia if you see it. So I have students say, well, I couldn't do the ataxia. Do I score it? No, because you didn't see it. So if their hand is weak, their hand is weak, so they can't do the finger and nose, but it doesn't mean you score them for it. So keep that in mind when you're scoring the NIH stroke scale. I think there's 2 ones that you score only if you see it, and I believe it's ataxia and extinction or inattention. Sensory, noxious stimuli, push on their nail bed. Technically, I think it's supposed to do like a sharp sensation. And all the extremities, see if they can feel it. It's going to be very gross sensory loss. Not like, oh, well, I do feel it or I don't. It's going to be like, oh, I can't feel it versus I feel it. Aphasia, you show them like the stroke cards, and you have them read. You have them point out objects, and if they're unable to do it, then you can score them for different levels of aphasia. Dysarthria is really slurring of speech. Someone who's drunk slurs their words. So it comes in practice. I know that students sometimes having difficulties with aphasia versus dysarthria. Know that dysarthria is more of a muscle. You don't have the muscles in the mouth here to produce speech, whereas aphasia is more cortical. You can't comprehend or get speech out, not due to a muscle structural problem.
Yeah, and even like with dysarthria, just to add on to that, like I also like with like the muscles, it's like I think like the quality of the speech. So, Dr. Adi, are you using the new postcard for, what is it, remember what we talked about yesterday? Remember we now have the man washing the dishes and the...
I got you.
It's great. And the lady is now mowing the lawn. It's
finally.
Yeah, so there was a study that was trying to make the stroke cards more appropriate and less sexist. And so we were able to find the paper, and the paper, instead of the woman washing the dishes, it shows a man washing dishes. And it now has someone outside, a female mowing the lawn. And then they had a different iteration where it's like a multiracial family. And I'm like, yes, it's about time. So I'm hoping that eventually it gets, what's the word?
Adopted.
Yes, I love the word adopted into
adopted globally.
Yes.
No, absolutely. I had a quick question before we moved on.
Yeah.
And I was like, when you said it, I was thinking about it. I couldn't think of the answer, but you said you only test horizontal gaze during stroke. Why only horizontal gaze? I was trying to.
It has to do with anatomy. That's a phenomenal question.
Okay. I just wanted to know if there was something.
It has to do with, that's a great question. I will look into that. Let me write that down. It has to do with the anatomy and that like vertical. Let me stop spitballing. Something to do with anatomy, and I'll look into it, and then I'll let you know.
Okay, I just was.
But that's a great question. Why testing only? Cool. Awesome. So, and then we have extinction. So basically there's multiple kinds of extinction, visual, and you can do sensory. So it's really getting at neglect. And that's a non-dominant parietal dysfunction if they do have neglect. So how you test for visual is you wiggle your fingers in their corner of their eyes, and then you ask them, which finger do you see? Wiggling. And you've already ruled out they're not blind, so they have full visual field is intact. But if you're wiggling both fingers and they say, oh, I only see one side, but it's like you have to wiggle at the same time and they're only seeing one side, but you know that when you tested the visual field, their visual field's intact, then they're just neglecting that one side. So you can test it with vision. You can also test it with touch. You touch them on both sides at the same time. And then you ask them, what side do you feel? But they won't be able to feel, let's say, for example, they have neglect on the right. So you touch them on both sides. They say, I only feel the left. But when you touch them one at a time, they feel the right and they feel the left. So, but when you do it at the same time, they're only feeling the left. And that's because they're neglecting that other side. So that's the stroke scale. So for this gentleman, he has a 19 on admission, and they did serial stroke exam post TPA. And you can see that the TPA is working because it goes down to 9. Check the INRs 1.2. So they do a CT head, shows this hyperdense sign. And you can see that sometimes in stroke and localizes the middle cerebral artery, no other signs suggestive of ischemic stroke. So let me show you guys what the hyperdense sign is. So this is what it looks like here. So we feel that this person probably had a right MCA, ACA stroke. So you would really focus your attention on that side. And what's happening is that the clot can sometimes be hyperdense on CTA head without contrast. And if you see that, you're like, holy crap, this guy had stroke. You make sure there's no evidence of infarction, but you really make sure there's no evidence of bleed. And in this case, there's no bleed. So you give the guy TPA and he's getting better. Let's see what else they have to say. Was made. Now I'd be curious to see what the CTA shows, because this right middle cerebral artery trunk. Oh, look at this performed CTA head and neck that shows he had a huge thrombus from the right internal carotid artery through the right middle cerebral artery trunk, which makes sense because if he has a clot in the MCA, let me just show you guys the circle of Willis. Because we were localizing his symptoms to not just the MCA distribution, right? Mm-hmm. Because he had the leg involvement. So we know he had a clot in the MCA because of the speech and the hand, but he also had leg. So that means he also had ACA distribution. Mm-hmm. So in order to hit both of these distributions, he had to have something, a clot or blockage more proximal, or he's doing multiple clots throughout his entire brain. So they do a CTA head and neck, or they do a cerebral angiogram, and they show that he has a clot in his internal carotids, which explains his symptoms. Let me find an image.
Okay, because the internal carotids feed into the MCA and the ACA.
Right.
Say it again.
I say because the internal carotids feed into the MCA and the ACA.
Exactly. I'm trying to find an image that will show that.
In fact, the MCA comes directly off of the ICA. And then you have the ACOM and the ACAs.
Mm-hmm. You're right. So here's the aorta, and you have the left common carotid, then branches into the external carotid artery and internal carotid. And as you scroll up, the internal carotid branches into the MCA and ACA. So if he's having both MCA symptoms and ACA symptoms, well, then he must have something here, or he has something here and here that's probably coming from his heart. So that's why his localization, the clot, makes sense for his symptoms. Does that make sense to everyone?
Which is why I love neurology. It makes sense.
It's like we knew where the lesion was before we did the imaging.
Exactly. We spotted it. You knock out both ACA. It's proximal. It makes sense to anatomy. Neurology is so neuroanatomy. It's insane.
Oh, it is. It is. You guys, that was my hardest course in med school. Like it kicked my derriere. Yet I still went into neurology. So after they give him TPA, he undergoes mechanical thrombectomy, and they perform it within 4 hours and 20 minutes. So another thing, what is the time window for mechanical thrombectomy?
6 to 24, or 24 is the
Exactly. So sometimes we'll have patients that will come in 5 hours after symptom onset. Are they a candidate for TPA?
5, no.
Exactly. But there might be a candidate for mechanical thrombectomy. So so you can do mechanical thrombectomy up to 24 hours. Let's see what else they did. So this
patient, from the emergency department standpoint, anyone who comes in with symptoms suggestive of stroke and it's within 24 hours, we'll just call code, because you still want to expedite the imaging, the workup, to make sure they're still a good candidate for thrombectomy.
That's a good. We do the same thing at our hospital too. So now that we've done the acute management, acute workup, this guy has gotten TPA, he's gotten his mechanical thrombectomy, going to be admitted now because the MRI is not going to happen in the ED. So when he gets admitted to the stroke service, we want to do an MRI because an MRI will tell us, did he really have a stroke? Like you look at that DWI scan and that will show you, did he have a stroke? So they do MRI, they look at the perfusion weighted sequence, and it shows perfusion weighted MRI shows perfusion abnormality indicating presence of substantial. Oh.
So would this be superior to, well, I guess it would be. So this would be superior to a CTP then, right?
You could do perfusion weighted imaging on MRIs. Let's look that up. I didn't know you could do that. I thought you could, it was always with the CT. Well, that's new. Interesting.
So then I wonder which one. So then it's kind of like CTP versus perfusion with MRI. What's superior, or what's available, or MRI is more expensive. So
you're not. I've never. It's rare to get an MRI in the emergency room. Like the protocol is CTA, head and neck, CTP, based on
We like CTs because there are fewer contraindications to CTs versus MRIs. CTs are quicker. Mm-hmm. There are a few things in the emergency department for which we will get emergent MRIs. None of them stroke related. So yeah, everything is CT really as it relates to stroke.
Awesome. And then here's some other just additional workup. Medical management discussed with patient and family. TPA was given 2 hours after onset. Thrombectomy initiated at 3 hours. Like we said, admit to the stroke unit, 24-hour monitoring depending on what your hospital is. And let's just get into more like inpatient workup that we won't worry about for now. Cool. So that's that case. Shall we do some more?
I do have to leave.
Okay.
Yeah, I know. I would have to do a block of UWorld before bed.
You do what you gotta do.
Step right now, actually. So I'm in dedicated. I know. So this was a great neuro review. I was like, oh man, like let's bring out the Circle of Willis, and And I just wanted to come in for a little bit before I continued on, and then, had to sleep and wake up really early. I know.
Well, thanks for coming. You do what you got to do. And I'm glad that this, helps. And
it was very helpful.
With the block study. Good luck with step study.
Yes, good luck.
Ooh, I know. We're trekking through. I think it's like the first week. So we're just going. So, but thank you. I do want to attend more. These were very helpful.
Cool. Yeah. Awesome.
It was great seeing y'all. You too, Joanna. See y'all later.
Good to see you.
Bye, y'all. Thank you.
See ya. Okay, let me pull up another case.
I really respect a second year student to come on here. I mean, first of all, you guys are like the experts, A, and B, I was not that astute as a second year. So that is insane.
Hardcore.
Good for her. Hardcore, right?
So that's awesome.
That is
agreed.
Pull up some more cases.
This is a good reminder. Let me do one more case. You can hear my daughter.
Oh, is that baby Ivy?
That is her.
Oh,
so I can do one more case, and then I have to get off too.
Okay, no problem. Let me find another case. Or, oh, here's, let's do this quiz. Here's a really good one that I found online. We can do some rapid fire questions that I think will apply to everyone's field. Okay, let me pull up.
Oh boy.
You got this. So this is recorded. Which intracranial vessel is occluded?
Well, I see some okay. Is there something going on in that left, like right there? What is that going on right there? Left area?
Yeah, I would think that's the...
Like MCA-ish, proximal,
yeah.
M1?
That's what I would say. Let's put it...
Wait. What are you guys even looking at? Left over here, what are we seeing?
Right there.
You tell us, Addie.
I'm asking the question.
So the question is, what intracranial vessel is occluded? And so the only vessel you really see on CT that could be occluded is the MCA. And you see this.
Like, you're looking at the actual, okay. You're looking at the hyperdense
sign.
Okay, I thought you were looking at the parenchyma, for parenchymal changes. I'm like, I don't see anything. But that makes sense.
Yeah. Well, at least that's how I interpret it, but the way you interpret it makes sense too. But
you would know better than me. Hold on, scroll through again.
I've not seen any hypodense regions, except this guy obviously doesn't have a good brain.
Yeah, okay. All right, then I agree with you guys.
So we're saying the left MCA.
Okay.
Awesome. So let's see. Name the sign in the previous image.
Hyperdense.
Oh, okay. That gives it away. Great.
Here's a good one. What is the most likely clinical deficit at presentation? So this is a perfusion scan.
Oh boy.
It
is hitting the cortex. I would say definitely like the face area over there.
So this is the left side of the brain. So we're probably going to think right-sided symptoms.
Yeah, definitely.
So what gyri is this hitting? This is probably because like post-central would probably be back here somewhere. So this is going to be pre-central. Am I getting this right? Yeah, post-central, pre-central gyrus. That's a lot of motor stuff. So this would be motor. Would this be arm or leg?
I thought that would be more arm, right?
Yeah, because of the homunculus.
Yeah, but wouldn't it also be some face in there too?
Yep.
Because you're hitting that, yeah.
Okay. I like hearing your your framework, right versus left, motor versus sensory, and then like where in the body. Okay, keep going.
Yeah, because that's how they teach us, you know, like to think through things in neurology is like, okay, where is the lesion? What's the what's the laterality? And then what do I know that's important in that region of the brain? And then I do all this before I look at the answers, because that's like a testing strategy. Because if you look at answers, sometimes it could like, you know, like
skew like you're thinking.
So now let's see what some of the answer choices are, and let's hope that our answers is in there. Oh man, they would do this.
What do they? I can't read the answer choices. What does it say?
It says agraphia, acalcula, aphasia, or agnosia. So agraphia means inability to calculate, and they're getting it like.
I thought that was acalculi.
Oh, sorry.
Calculate. So I think agraphia is writing.
Yeah,
like writing.
Sorry.
Which I believe is,
yeah, that's the arm.
Well, no, I think agraphia, I thought that's more basal ganglia-ish.
They're getting at that Gershman syndrome.
Oh, wow. Wow.
Yeah. And Addie, this is more neurology.
Oh, acalcula is mathematics.
I can still learn it.
Yeah. So basically, there's this Gershman syndrome. It's one of the Nih Stroke syndromes. And let me find a good image. So here, this is a really good one. Let me remove.
I need to join this on my, hold on. I think I'm going to join on my computer because I cannot see anything on my phone.
So actually, I'm going to copy. This is a really good image. So Gershman syndrome, inability to name their own fingers, right-left confusion, acalcula, can't perform calculations, and agraphia, inability to write, like you said, Laura. And so this is really like a this showed up on step 3. They love these Nih Stroke syndromes. So unfortunately, just you gotta commit this to memory. So it's usually the dominant left inferior parietal lobe. So when you think of a lesion in this area, think they can't one of my attendings said, think about things that kindergartner is supposed to be able to do. And then people that have the Gershman syndrome, they can't count their fingers. Looks like Addie's joining.
And you're saying this is usually dominant parietal? Or non-dominant? Because non-dominant is like the neglect and the so this must be the dominant parietal then?
Yep.
Okay.
Yeah. Hold on. I lost my screen. Okay. Let me go back. Okay. So that's where they're getting that. So if we go back here, this area is too superior to be the parietal. So it's not going to be agraphia because that would be Gershman. It's not going to be acalcula because that would be a Gershman. It's not going to be agnosia because that's
also Gershman. Yeah.
So then it's aphasia, and that makes sense because that's like, Broca. That's like Broca's area. It's more like frontal. Does that make sense?
Yeah.
That's my guess. Awesome.
What's the answers as we go?
Here we go. It asks us, which functional area of the brain does this finding correspond to? So what do we think?
I guess you were saying the precentral gyrus, right? Or are you, is this in reference to the previous question or?
Yeah.
Oh, okay, then, well, that would be Broca's then. Okay.
Because Broca is speech. Warnke is more further back. Broca is more in the frontal production of speech.
The expressive aphasia, right?
Yeah. Which type of advanced imaging modality is portrayed above?
I guess it's got to be either the diffusion or the perfusion.
So it's perfusion because the DWI, because I don't know, I've never heard of MIP or TDP. DWI is an MRI scan, and it looks like this is what it looks like.
Oh, that's right.
Yeah.
Yes.
Okay, so DWI is like CT.
No, DWI is an MRI scan.
No, I know, but I'm saying like the images will mimic like what you see in this other. Well, never mind. Maybe that's not a good way to think of it. That could confuse people.
What do you guys think? Ooh, this is a hard one. Ooh, which of the following artery is most likely to be affected? So this one, I would just look at the options and they can rule out things. So we know that it's not the posterior communicating, because I really don't see stroke symptoms from a posterior communicating artery. We know it's not the middle meningeal, because what's high yield for middle meningeal artery is
an epidural hematoma.
Exactly. So this is a DWI sequence. So it's either posterior carotid artery or anterior carotid. And this one, for me, it would be a guess. One of these has to do with the thalamus. The other one doesn't. Can't remember which. Anyone?
Boy.
So I would just guess this one. And we'll see what it is. And then we can Google it later. Ooh, which aspects area has been shown to be least sensitive? Oh, man.
Least sensitive? Oof.
So aspects, just to refresh everybody's memory, has to do, it's not really used a lot in stroke anymore, but I guess before they had CT perfusion, aspect is something that you get off a CT scan, and you're looking at different areas, hypodense regions, and it may be contraindication to getting TPA. So how they go about calculating aspect is that they looked at the CT, and if any of these regions, if this would stay still, if any of these regions here are abnormal on CT, then you get scored each region, like M1, M2, M3, 4, 5, 6, and then the basal ganglia, each region gets scored 1. So if you have an issue here, then the highest score is a 10. 10 means your entire brain is normal, and that's a great score. It means there's no evidence of hypodense or signs of infarction in your brain. And then if you have hypodense region in M1, then that's just -1, then your score becomes a 9, and every region is equal to 1. So if your score is too low, then you won't be a candidate for TPA, because it means that the stroke has already completed, because now we're seeing evidence of tissue death on CT. That's where that comes from. I don't see it used a lot because we have CT perfusions. So which aspect has been shown to be least sensitive? This one would just be a guess. I don't know. That's a guess. This is more like a stroke fellow question. So to give you guys perspective, which deficits will you see with blockage? Oh, we talked about this a lot. Middle cerebral artery. So what do you guys think?
I particularly like hemiplegia.
Are you guessing?
Like, okay, so not, let me see, let me go through here.
Yeah. Remember, we walked through it. You know that the MCA.
Oh, it says check all the apply. Oh, I love that. Okay. Look.
So
you can technically have global aphasia if you wipe out the whole MCA. I mean.
Sure. You're right. I was just giving you a hard time. You're right about the hemiplegia.
And then not the ipsilateral limb weakness. No to that.
Good.
Contralateral gaze palsy. I guess you can do the contralateral gaze palsy.
Is that the one where she talked about
frontal eye fields?
But I thought that was ACA.
But theoretically, if you knock out the proximal MCA, you would be not that again, if that's it's
okay, let's technically
try it is we I mean, I guess, I mean, I could be wrong.
It's all good. And it's good to be, if we're wrong, good to be wrong here now, so that, you know, when you're on rounds or you're taking the exam where it actually matters, you'd be like, I got this, and boom, then you're right. So.
Yeah, and then the bitemporal, that's going to be with pituitary tumors there. So that's a no.
Good.
So spatial neglect.
Sensory loss. That's going to be.
That would be the thalamus, yeah. More of the thalamus, I would say.
Well, for hemisensory loss, that would be post-central gyrus, and the post-central gyrus is right behind the precentral.
Right.
So.
And a lot of the sensory strokes are like they hit the thalamus, I think.
Yeah,
what's the spatial neglect? What about the spatial neglect? What's that really?
Let me show you the post-central gyrus to see if I can convince you that is MCA territory. You see?
Mm-hmm.
So, yes, the spinal tracts for sensory go through the thalamus, but they all terminate at the post-central gyrus, which is part of the MCA distribution. That's why when we do the stroke scale, part of the stroke scale is sensory deficits.
Right, you're right, yeah.
So, I think, Laura, what you were getting at is if you only had a sensory deficit, then you could localize it to the thalamus.
Yeah.
But if you had that plus these other things, then you'd be worried about MCA.
Agreed.
Yeah,
Agreed.
Yes, where did the questions go?
Yeah, I would like the spatial neglect. Is that more of like the spatial neglect?
Oh man,
is that more of the non-dominant parietal lobe situation?
You guys, I think I accidentally clicked submit. Sorry. Where did our questions go?
We failed.
We failed.
What? You submitted it. Sorry, y'all. That's my fault. Where are the questions?
No, but you can't even get the results. You have to give them your email address to get the results. That's not cool.
It's not cool. Where'd the questions go? Hold on. How many
really failed?
Oh no, we failed like, I think I saw like a 32%.
I saw that too. I saw failed. Like I saw capital letters.
Y'all are funny.
OMG.
Where did our questions go? Sorry, y'all. I messed it up.
But we only did like what, 1 page? Not even a fourth.
Whoops.
And we got more than 25%. That's good.
So actually
I messed up. My bad.
Not bad at all.
My bad.
Oh, good. This is a good learning. I've learned a lot.
Me too. Thanks for joining. Did we do this one last time, or is this one we got to pay for? No, we did this one last time. Close all tabs. I have a book that we can. That's what I probably should start with. A book that we can actually put up. Let me pull up some more. 1 second. Where we actually have the answers, and then y'all can see. I've done this one before, but this one has answers. Y'all can see how horrible I did, but it's learning. We're learning. Can you guys see my screen?
Yes.
Yeah.
Awesome. So, so this one is basically like high yield stuff to know from a stroke standpoint. So here, you have a 51-year-old female, type 2 diabetes, blood pressures are as follows. Which of the following interventions will most likely reduce the patient's risk of stroke?
Hypertension.
Yeah, right. I remember a stroke.
If it's not hypertension, it's smoking.
Oh yes, smoking. They love that smoking stuff. Yes.
Oh,
too.
Because I had a stroke doc tell me what are the 5 top causes of stroke. He said that the first 3 were hypertension.
Yeah, I mean, we literally have a name like hypertensive emergency. They come in with stroke.
Yeah.
I see a lot of patients with hypertension with stroke compared to those with diabetes and stroke.
Yeah, Yeah,
Now,
that's the worst.
interestingly, for AAAs, it's smoking. That's the number one risk factor. But for stroke and aneurysm rupture, it's hypertension.
And hypertension.
Okay, what about this one? High levels of LDL most likely associated with the following types of stroke.
Yeah, that's atherosclerosis. Yeah.
And so we can talk about the others. So what's the answer for cerebral infarction due to cardioembolism?
Oh, AFib, are we talking here?
Yeah.
Or okay.
And then what about deep intracerebral hemorrhage?
I still think that's hypertension, right?
Yeah, you're right.
Yeah.
And then what about lobar intracerebral hemorrhage?
I'm just gonna go with hypertension.
I would too.
It's actually cerebral amyloid angiopathy.
Wait, can you say that again 10 times?
Cerebral amyloid angiopathy. Let me show you guys what that is.
Cerebral.
Basically, it's like buildup of amyloid, which is the same protein that builds up in Alzheimer's.
Like hearts? In the heart as well, or like in the kidneys?
Actually, so that's a different kind of amyloid. Like it's amyloid.
Like it's like the beta 2 or like the alpha, like it's the different, okay.
Yeah. So with this one, in old individuals, what happens is you have this amyloid, it's an abnormal folding of a protein that builds up in the blood vessels. And those blood vessels then become weak and they like to bleed. And if we see on a CT a patient, here's some, see? So here's a image. So if we see a patient CT head and they have a lobar hemorrhage, not a deep hemorrhage, so deep hemorrhages would be here in the basal ganglia, and this is due to hypertension, like you said. If you see a CT head that shows a lobar hemorrhage, think underlying CAA.
What causes that? What causes CAA?
It's an abnormal buildup of amyloid. So there's a debate in the field. Some people think it's related to Alzheimer's disease. Some people think it's a completely separate process.
Is there genetics involved in this?
It's a very small minority of people have a genetic component. It's really debatable. So it's not fully understood.
And it gets built up?
Huh?
Like your body's supposed to remove it and it doesn't? Or
exactly. It's an abnormal misfolded protein that the body can't remove. So it just clogs up in places and it likes to clog up in blood vessels. And so if you see something like this, it's a lobar hemorrhage on a CT head, and they ask, well, what's the etiology or what's the underlying etiology? It's not hypertension, that's CAA.
I would have guessed like a mass or tumor. That's good to know. CAA. Okay.
Yeah. So let's see. Awesome. And then subarachnoid hemorrhage. What causes subarachnoid?
So hypertension again.
Huh?
Hypertension again?
Oh, it's
really. This
is high yield for step exam. It's aneurysms, actually trauma.
Oh,
subarachnoid hemorrhage.
Of course.
Trauma. And if they haven't had a trauma, if it's a non-traumatic subarachnoid, you think aneurysm. Rupture aneurysm.
Yes. Okay, yes.
And they like that. So remember that for your step exam. Subarachnoid hemorrhage, rupture in a berry aneurysm.
That's correct, yeah.
Okay, so now we have a 50-year-old female, has hypothyroid, she smokes, she's overweight. No, she's not overweight. Which of the following interventions will reduce her cardiovascular risk? And like you talked about, Addie, smoking. Smoking is bad for the heart, also bad for the brain. Okay, let's look at question 4. 74-year-old, difficulties moving the left side at 8. So if he's having difficulties moving the left side, where does that localize to?
Oh, right side.
Good. He felt completely normal when he slept. So we would call this a wake up stroke. And we say that because he was normal when he slept, and then he woke up and now he has stroke symptoms. And we don't know when his last normal was per se.
But
we don't know,
out the window.
Right. We don't know if he's normal, if he stroked at 7:59 a.m. or if he stroked at 10:31. So he typically, when someone wakes up with the stroke, we don't give TPA, but we try and see if we can give mechanical thrombectomy. And these are the cases where we're getting the CT perfusions to look for that core mismatch. Because we don't get CT perfusions in all cases. Awesome. So now he has a left homonymous hemianopsia. So where would that localize to?
Right, like as far as the right MCA territory.
No, right brain.
Right brain. Okay.
It's occipital lobe.
Oh my gosh, sorry. I don't know what's going on with my brain today.
No,
You're right.
Okay. That's okay.
This is vision. Yeah.
Yes. So what territory, ACA, MCA, or PCA?
So for that would be PCA, right?
Yeah, very good. And then he also has weakness and numbness of his left face and arm. So that
would be the MCA.
Yeah, right MCA. Arm would be what?
What was the question? Sorry.
Where would weakness of the arm localize to?
To the MCA territory.
Yeah, very good. And good. So right now, all this is right symptoms. Oh, check this out. So he has multi-vessel, what do you call this? Symptoms. So he has, is his leg, or just his, okay, he has face, arm, that is MCA on the right. He has left homonymous hemianopsia, that's PCA on the right. So he has MCA distribution and PCA. So they show a proximal M1 occlusion. And I'm surprised he doesn't have anything against PCA. So he has a proximal M1 occlusion and some saltable tissue in the right middle cerebral artery, no hemorrhage, and no early ischemic changes. So it means he can't get TPA, but they can go remove that clot. His blood pressure is fine, 150/90, which the following is now indicated. So you can tell I took this before I knew anything. So now we know it's not labetalol. I don't know what the blood pressure is for mechanical thrombectomy. I don't think there's a high cutoff like there is for TPA. But in this case, you would give mechanical thrombectomy. Let's see what they have to say. But does that make sense?
Right.
So let's see, patient finding stroke, some evidence use of IV TPA, onset. Okay, so it looks like they don't talk about a blood cutoff for a blood pressure cutoff for mechanical thrombectomy, because I guess you just want to remove the clot. So now we're on question 5. Take it away, Laura.
A 64-year-old woman is being evaluated in the emergency department 30 minutes after she suddenly developed right hemiparesis and aphasia. So I'm already kind of thinking like left hemisphere here, with the aphasia in the frontal lobe. While visiting her husband in the hospital, her blood pressure is 150/90, so there's no contraindication for TPA. She's within the limits. The remainder of the exam is consistent with an ischemic stroke in the left MCA, and a CTA shows occlusion of the M1 segment. She's about to be transferred to a nearby stroke center for a mechanical thrombectomy. Before being transferred, which of the following medications? Well, looks like we're dripping and shipping.
There you go. Exactly. Now, we want to give atorvastatin, that's for secondary prevention. We want to give IV heparin. We want to give labetalol because blood pressure is less than 185/110. And mannitol, that's really used for elevated.
ICP,
yeah. And you know all about that. Awesome. So let's, number 6, which is the following patterns of early ischemic changes on CT would be assigned an aspect of 10.
So much from this, but I have to run.
Okay, thanks for coming, Dr. Akatuhaman.
Of course.
It's
been nice
lovely.
Meeting you, Laura.
It's been a pleasure. Thank you so much.
See you next time.
Next time. Bye.
Bye-bye.
Bye.
So the highest aspect score is 10. So we would expect for the brain to be pretty much completely normal. So
yes.
That's answer E. And I guess we can take turns doing the questions. How does that sound for you?
Sounds good.
Cool. Okay. You're up.
Which of the following medications should be discontinued for 48 hours after CTA? Oh, is this because of the contrast? So like I know metformin for contrast for the kidneys. So
yeah. Really?
The contrast-induced nephropathy. Oh, there it says. Boom.
For metformin?
Yeah, so that the contrast-induced nephropathy can cause acute tubular necrosis. And so anytime someone, even if people don't come into the hospital for a stroke, if they are on metformin and you suspect that, you'll need to do a CTA of anything, whether it be the abdomen or whatever, people's metformin are usually held just precautionarily. So because of that risk there, it's actually not that high of a risk, but when they do get this contrast-induced nephropathy causing acute tubular nephrosis, you'll get like those muddy brown casts. The urine will be like super dark. And they go into acute kidney failure, which means like their creatinine will like massively jump like within 24 hours. So they're very cautious about this metformin business.
I didn't know that. Thank you. Awesome. So metformin, it causes the acidosis and that it can affect the kidneys. Thank you. I did not know that. So then patient spontaneous intraparenchymal hemorrhage has a linear contrast density within the hemorrhage, a spot sign, not a anatomic or continuum of any adjacent blood vessels on CT. Which of the following will happen? Hemorrhage will probably grow larger. So let me show you what the spot sign is.
Yeah, I was going to say, this is so beyond my knowledge base at this time.
You know what I'll do so that I don't overwhelm you? If I feel that it's high yield for you as a M3, then I'll explain it to you. How does that sound?
Perfect.
Okay. So don't worry about question 8.
Ooh, I'm like, that went over my head. So I'm doing step 2 in like within the next 6 months. So anything step 2, I'm here for it.
Cool. We'll focus on step 2 stuff. Let's see, which of the following may increase risk of duration of survivability after acute stroke? Ischemia preconditioning.
Oh yes, actually, there's a protocol that makes sense. Do you mind actually going back?
Yeah.
Oh. Okay. Increase the duration of right, which is why they do that temperature. There's like now a new term for it, temperature, like we basically, what is it called? Oh my god, like the ACL's protocol where you bring people's temperature down to 32 degrees or something like that, like the temperature hyperthermia, like even after those people who have achieved ROSC, so those heart patients who achieve ROSC, and even stroke patients, they do temperature. Let me just look at the real quick. Temperature. Sorry, give me a second.
Oh, give me 1 second. I gotta take this phone call. 1 second. I'll be right back.
Okay.
I am back. Okay. Ischemia preconditioning. That's good to know.
So that tells me then that your hospital's probably not doing, at least not in the stroke unit, not doing the target, like it's called like targeted temperature management. So that's standard for patients who have achieved ROSC. In the heart hospital. Basically, they cool them. It's like this big process. So don't quote me on the numbers, but like you cool them for like 12 or 24 hours gradually up down to like, I don't know if the magical number, like between 24 degrees to 32 degrees. And then you like rewarm them back up. But like the purpose of that is to delay ischemia. Basically, if you make the cells in your brain cold or in your body cold, like it slows down all the enzymatic processes, slowing down ischemia. So I don't exactly know if research has proven for strokes how effective that is.
Okay, because I've seen it for like cardiac arrest patients. I didn't know they were doing it for stroke patients.
So when the hospital that I was practicing at as a registered nurse, we were doing that not only for heart patients but also for stroke patients. So.
Oh, I see. Oh, thank you for that. Huh? That's good to know. Let's see. Okay, this one, you tried this one.
A 65-year-old man arrives in the ER 9 hours after onset of MCA syndrome. So we're out of the TPA window here. Which of the following findings on CTP in this patient suggests he will most likely benefit from endovascular therapy if a large vessel occlusion is seen? I know there are some like, so I'm just kind of going through the answers. Well, C is clearly normal, right? No core, no perfusion. So like that's a normal CT.
Yep.
I know that you were mentioning like you're not a candidate if your stroke is greater than like 1/3. Yeah. So it can't be, basically you can't have a too large of a large.
Yep. Yeah, you're right. Because if the core is too large, then that means that's just a lot of infarcted tissue. And there's nothing for us to save. So you want that mismatch of you have a really small core and a huge penumbra, because what you're saving is that penumbra.
Okay. So the perfusion, the when it says the perfusion mismatch, is that for the core or is that for the penumbra?
The perfusion is for the penumbra. So
okay, so then that means you would benefit if you have a larger penumbra, but if you have a large core, then that means a stroke is too big.
Exactly. And so here's an image. So what's going on in a stroke? You have the tissues around, the tissues most proximal to the actual blood vessel. Those are going to die off first. And what's saving the other tissue is the collaterals that come off other branches of the cerebral Lupus. So
and it's kind of like you've got the infarct and then you've got the ischemia. And the ischemia is what we're trying to prevent and see what we can do about the ischemia, basically.
Yeah, in a way, because infarcted tissue is dead tissue, and then the tissue around it is just hypoperfused tissue that will die if nothing.
We don't do anything.
Yeah. And so that's the penumbra. So if you look here, let me get my annotation. So this red looks like the core. So the red is the 30 mLs, and then the penumbra around that is the 32. So you just want a high mismatch between the core and the penumbra, because then we can save that tissue that's not overlapping.
I see. So small core, large penumbra. Yeah. Okay. Gotcha.
And this is the stuff that that you'll see on your stroke rotations when you're in residency. So that's that. So D is the right answer. This one's a resident level question. Which of the following conditions may result in overestimation of penumbra on CT perfusion in a patient with acute middle cerebral artery syndrome, ipsilateral intraternal carotid stenosis? I still don't know that one. Don't worry about this one. Resident. Recent clinical trials of endovascular therapy in patients with acute ischemic stroke and perfusion mismatch treated 6 to 24 hours after symptom onset, demonstrating increased likelihood of which the following outcomes compared to mean. Yeah, so that makes sense. If you remove their clot, functional independence. So that's why we love, that's why we do the mechanical thrombectomies, is to improve their functional outcome. So this will be a good method question.
Okay.
I'll help you through it.
Please. Which of the following MRI sequences is most useful for identifying asymptomatic cerebral microhemorrhages? Interesting.
Yeah. So, you know, what is diffusion weighted imaging? That we use for stroke.
And that's that MRI?
Yeah. And so the images you want to you look at for stroke is the DWI sequence. And if it's white, remember this is with the water restricting. Mm-hmm. So if dead tissue does not allow water to osmose through the plasma membrane, so it's going to restrict water. And on DWI, the bright areas are areas where water is restricted. So that means that tissue is dead. So that's for stroke. So if we go back to this question, this is asking about microhemorrhages. So we know that DWI is not the answer. And then fluid attenuated inversion recovery, that's T2 flare. That's another type of scan on an MRI. Basically, it just, so here, the different scans on MRI, you have T1. So T1, white matter is going to be white, gray matter is going to be dark. And then you move to T2, where everything's opposite. White matter is dark. So you see here, this is the white matter. Here it's dark, but here it's bright. So on T2, white matter is dark, gray matter is bright, and CSF is bright. Unlike on T1, gray matter is dark, white matter is bright, and CSF is dark. And you really use T1 to look at anatomy. T2 weighted, we don't really use it a whole bunch in stroke or in neurology, but we're really focused on T2 flare, because what happens is T2 flare, they subtract out the CSF to where it's black, so that you see how we can see better the gray and white matter, because we don't have this bright CSF like affecting the image.
Yeah, yeah.
So that's the key things. So it has nothing to do with blood at all. It doesn't really highlight blood. So they're asking us about this image here, T2 flare. Can we see microhemorrhages on T2 flare? And the answer would be no, because we, that image just, it's highlighting the anatomy of the gray and white matter. Is not specific for
microhemorrhages.
Yeah. And so we talked about T2, and then that also answers T1 and T2, because T1, we showed it, that really highlights anatomy. T2, same thing. The CSF is bright. T2 flare, CSF is dark. So that leaves us with SWI. And that really highlights microhemorrhages. That's why we get the SWI, to look for microhemorrhages. So let me show you what a SWI looks. This is more like intern level question, MRI. But I've seen, we also teach this to medical students when they're on the stroke service.
In patients with microhemorrhages, those would be more classically patients like with like valvular, like MR, like flicking off stuff, or like septic emboli flicking off stuff.
Yes, exactly. Yep.
Okay, fair enough. Okay.
And so let me find a good one here. It's kind of hard to see on this one, but looks like they're black spots on SWI represent microhemorrhage. This is kind of hard to see on this one. Oh, here's a good one. So you see, let me get my pointer.
How is radiology integrated into the neurology residency program? Like, is it just, it's just part of it, or do you specifically have like actual like didactic or something like that? Like,
yeah.
How does?
So there's a radiology rotation that we could take if we want as an elective, but especially anytime a patient gets an image, we walk through it together as a team during rounds. And so then I can learn how my attending is reading scans, what I'm supposed to be looking for. So the rule of thumb is anytime you have a patient and they have an image, look at it yourself.
So you're okay. So it's really like it's like an on hand, like on site, like it's not like dedicated radiology 2-hour like situation every Friday. It's like it's part of like, it's just, it's part of like your everyday. Okay.
Yeah.
And it's like the more you see, the better you get. Like,
exactly.
Okay.
Yeah. Because it depends on the program. There's some programs where it's like they have, not only do they have like it every day, but they also have like a dedicated, 2 weeks or a month to just look at scans. So but yeah, the more you look at it, the more it'll pick, and I think as a PGY3, as a medic M3, the basics are knowing what is T1, how to differentiate between T1, T2, T2 flare, and DWI, like how to just recognize that. And because we explain that to med students on, when they come on the stroke rotation. I think once, if you know that, then you're great for your board step 1 or step 2, step 3, and your stroke and your shelf.
Okay, thank you.
Yeah, no problem. And so that leads with SWI. Which of the following common sites of hemorrhage? Which of the following common sites of microhemorrhage is associated with patients with hypertension, thalamus? So that's really like the deep cortical structures.
I was just going to say something in the basal ganglia. So that's the thalamus being part of that. The gray white matter junction, isn't that like the classical site for like metastatic brain, brain mets? Okay.
Yep. Great. Yeah, exactly. Let's see. Which of the following clinical parameters has shown to correlate with total cerebral burden of white matter, hyperintensities of presumed vascular origin? This is definitely a resident question. Don't worry about it.
Woo.
At minimum, a diagnosis of embolic stroke of undetermined origin. This is resident question. Let's see. The best available evidence supports which of the following long-term antithrombotic strategies for secondary stroke prevention after embolic stroke.
Secondary prevention, understood. Okay.
Oh, this is a resident level because.
But we talked about this actually. We did. We mentioned secondary stroke prevention, like statin, aspirin, and statin and aspirin. Okay. In this case here, we have the single antiplatelet agent, assumingly aspirin here, but I guess Plavix either way.
Yeah. Let's see. Based on the available evidence, which of the following is optimal for dual antiplatelet therapy after high risk transient? Don't worry about this. This is resident level. A patient with ischemic stroke. This is awesome.
Oh, the PFO. Yeah. Yes. Those are like the paradoxical emboli.
Yeah. I actually saw this on a shelf question once, and it was like, let's talk about it. So we have a patient that has an ischemic stroke in a pain-terminal valley detected on echocardiogram. Which of the following features increases the likelihood of the patient to have the PFO to be the cause of their stroke? So how can someone that has the PFO get a stroke? Where would, if I have a patient in the emergency room and they have a stroke, and I look at their large blood vessels, and there's nothing there, their heart is clean, but they have a PFO, what else should I be looking for to explain why they had the stroke if I think it's a left-right shunt?
Oh, like as in like what imaging would you do, or what do you like?
I guess where did the clot come from? If it's not the heart, and if it's not the neck vessel,
carotids, like it's not the carotids either.
No. And then, but they have a PFO. So tell me the physiology of a PFO. What's going on in the heart?
Isn't the atriums, there's basically not closure of like the ovale, and then so it just allows for there to be paradoxical like blood flow between the left and right atrium, which then leads to...
So what kind of blood is going into the right atrium? Is it venous or arterial blood?
It's it's arterial blood.
Into the right atrium?
Into the left atrium. Oh, in the right atrium, it's venous. In the left is...
very good. So what's going on is that
so we have arterial blood going into the venous blood.
Yeah, and then you also have venous blood going into the arterial system. Deoxygenated blood going to the arterial system. So what can happen is you can have a clot from the venous system go into the arterial system if you have a PFO. So in this...
So you're saying it's usually a right to left versus a left to right? Because I usually think about it like, it's like arterial blood, this is a high pressure system, venous being low pressure. So assumingly there would be a lot more left to right shift. Yeah. But with the you're saying with the PFO though, usually it ends up being a right to left and then going just straight up the aorta going up.
Yeah. Okay. I guess it depends on like, the systems, but if someone has a DVT.
Oh, okay.
If someone has a DVT, that's in the venous system. But if they have a PFO, that PFO
goes from the right atrium then, because it comes up, it goes up through the inferior vena cava, and then it would go to the right atrium, going to the left atrium, then going right to the aorta. Okay.
Exactly. And then it goes up the carotids, and then it goes into the brain.
Exactly. Yeah. Exactly. Straight shot to the brain. Right. So
that's what they're getting at here. And I saw that once on some kind of med. It was like, probably like, it was one of the harder questions, but I saw that one. So just, there you go.
PFOs are interesting because I didn't realize people living with PFOs is actually a lot higher than we think. I think it's even up to 20-30% of the population have PFOs. And there's this whole, I remember sort of tuning in to sort of this hot controversy in regards to PFO closures and when should we do them? How beneficial are they really? And so PFOs are an interesting topic. And are they really, or is the clot really from the PFO, or did we not do our...
Are you sure you don't want to go into stroke? I'm going to recruit you into stroke. I'm not a show doc yet, but I'm like, I think you should go into stroke.
And the thing is, I genuinely love stroke and vascular. And I had this whole thought, I was like, I'm going to be an endovascular, I'm going to be
phenomenal. You're miles ahead of the game.
But then I'm like, but I'm a little bit older and I'm like, do I want a life or do I want to live?
True.
Do I want a life or do I want to live? Right?
I support you whatever you decide to do. I'm just being biased. So let's take a look at this one. So compared to women with normal blood pressure through pregnancy, women who have preeclampsia, that is not a medicine question. Let's see. In postmenopausal women taking hormone replacement therapy.
So hormone estrogen. So estrogen, not only what is this hormone? Yeah, that's usually with estrogen, I know sort of you want to limit the use of estrogen. If you're going to prescribe it, this is not like a long-term thing. You want to do it more so like, I don't know if like people are comfortable doing it for like 6 months to a year, but certainly not something long-term, and certainly like not if you're a smoker, and so, but I know hormone therapy, again, people were like, the creams are fine. Estrogen creams for vaginal atrophy, perfectly fine. But when we start to actually take oral medication, that becomes problematic. So I find that that's actually less used now because there are just so many more, there's just different products, on the market as far, but I mean, certainly an estrogen cream is not going to help with hot flashes, but it's just, it's a fuzzy area. It's like hot flashes versus stroke. I'll just take the hot flashes.
I know, right? Yeah, you're exactly right. They're trying to get away from doing like long-term hormone replacement because it's associated with high risk of stroke. Awesome. Evidence. Oh, I didn't know this one. Evidence shows that this one is the resident level. Evidence shows that which is the following, but what I could do is pull out what would be the med student level question for this. Evidence shows which of the following is a stronger risk factor for stroke in men and women. Answer is AFib, but I think the takeaway from a med student standpoint is the strongest risk factor of stroke in all people is?
I thought it was hypertension.
Yes, actually. It is. Yeah.
But I'm looking at the question. I would have never chose AFib. I had no idea. So AFib is more prevalent in women.
Yeah, it's one of those papers where they probably did one paper and it showed it. It doesn't get talked about a lot. But just know hypertension, stroke. This is a good question. Which of the following contraceptives is associated with an increased risk of stroke or MI? And you talked about it.
We love this. Oral contraceptives for sure, hands down. In fact, I have actually, unfortunately, in my years working in neuro ICU, I believe it or not, and I've taken care of, unbelievable amount of patients I can't even name. And I will tell you, I kid you not, I have seen so many young women under the age of 40 who end up having a stroke because of oral contraceptives. Now, granted, I think at least half of them were also smokers. So that is problematic. Okay. Yeah. So oftentimes, unfortunately, either that was not disclosed to either the OB-GYN in regards to their social, use of smoking or whatever the case must be, because I know for a fact, like OB-GYNs are extraordinarily hesitant on providing oral contraceptives to women who are smokers. Because there's so many other things on the market. There's the vaginal rings, there's copper in the devices. So there's so many different things. They wouldn't have chosen that. So it's just so unfortunate. That is very real. I will just admit to that. Lupus. Is this lupus?
Following acquired or genetic thrombophilias has greatest risk for ischemic stroke.
I'm really shocked, only because for me, I have personally, in my little experience, have seen more factor V Leiden mutation than I have and resulting in stroke than I had antiphospholipid syndrome. But that, of course, I can't take my experience and make it a whole, like this is facts and this is, no, that's just my little experience. But that's just interesting. I've personally seen quite a bit of factor V.
Yeah, and this again is probably, they saw this in a study and saw that when they did statistical analysis that it was phospholipid. But yeah, and what we do in patients where we can't find like an etiology, like it's not the carotids, it's not the heart, it's not like a PFO, then we'll go, we'll test for these enzymes or factor deficiencies and see, well, is it one of these?
Yeah, is it a coagulation problem? Genetic? Yeah, exactly.
And then I know it's time to clock. I want to respect your time. So if we have to go, we can always finish this later. Or if you have time, we can finish this. Whatever you want to do.
I would love to table this. This has been awesome. 9 o'clock is here and we can definitely finish this. This was awesome.
Ooh, well, thanks for joining. And I look forward to the next time, we're able to study together.
Yeah, Yeah, and it's so great to have an ER input too. Like, what goes on in the ER? Oh, like, it's so cool. So awesome. So I'm glad your sister was able to join in. That was
that's
awesome.
what I love about the study group. It has the potential to bring everyone in. It's not just people, neurologists or neurology trainees. It's people, because neurology shows up on our boards. It shows up on everybody's boards. Even in emergency medicine, they see neurology patients. So it's good to be able to pull in people from different, not only specialists, but different countries. And because I've had people I remember I had one study group where there's like 3 or 4 people from different countries and seen how they practice neurology. So it's been awesome.
Absolutely. Yeah.
Ooh.
Thank you so much. See you next time.
Yes. Have a great night.
You too.
Bye.
Bye.